Medicina en la División de Gastroenterología y Hepatología de la Clínica Mayo de Arizona. Ha sido presidente de la división y director médico de la Clínica Enfermedad Inflamatoria y es actualmente el presidente del Colegio Americano de Gastroenterología. Antes de comenzar, nada más quiero recordarles que vamos a tener las comidas. En el Salón 5 estará pancreatitis aguda, en el 21A enfermedades anorrectales y en el 22B va a haber diverticulosis y diverticulitis para que lo tengan en cuenta. Muchas gracias, doctor Leighton. Adelante.
Muchas gracias, Dr. Amieva and Carmona, for inviting me today again. And I'm going to talk on obscure and occult gastrointestinal hemorrhage. And I wanted to pick this exam showing some of the challenges with capsule endoscopy. If you look carefully, you'll see in one image there was something that passed by and it looked like that. But it was only in one image. And the question was that vegetable matter? It was only seen in one frame, and you never know what it means. But because this person was having bleeding, we did go ahead and do deep enteroscopy from the antegrade approach. And although I didn't know if we'd find something, lo and behold, we found that polypoid lesion with overlying erosions, and it turned out to be a polypoid hemangioma. Fortunately, we did remove it by surgery, and I didn't try to take it off endoscopically. So the approach to diagnostic small bowel bleeding, like anything else in medicine, is to do a thorough history because you want to understand the type of bleeding, whether it's occult or overt, the duration of the bleeding, any family history of underlying disease, medications, certainly anticoagulants or NSAIDs, and obviously in a woman, careful menstrual history, because we don't always know that it's coming from the small bowel. Then a thorough physical exam and lab testing, careful upper endoscopy and colonoscopy, and then, if negative, further evaluation of the small bowel. But the question comes up, when should you repeat standard endoscopy before going to a small bowel evaluation? And so it really requires a careful selection of patients to ensure a cost-effective approach. For example, in patients who present with iron deficiency anemia, other causes such as celiac disease, hematologic, and or gynecologic etiologies should be considered first. And remember that up to 25% of lesions can be missed on initial upper endoscopy or colonoscopy. And therefore, if the previous exam was limited to the bleeding or a recent high-quality exam wasn't performed, then we should perform second-look endoscopy first. Now, small bowel bleeding accounts for about 5 to 10% of all gastrointestinal bleeding, and capsule endoscopy, device-assisted enteroscopy, and multi-phase CT scanning can identify a small bowel source in 40 to 75% of cases. And therefore, in our guidelines, most cases of obscure bleeding can now be termed suspected small bowel bleeding, and then obscure bleeding is reserved for cases where no source is identified after a thorough small bowel evaluation. Now, how does it commonly present? Well, it can present as chronic intermittent and can be overt with hematochezia or melena, or occult with iron deficiency anemia. And the differential diagnosis are vascular lesions, NSAIDs, Crohn's disease, primary tumors, and metastases, and then less common radiation and portal hypertension. And we also have to remember extraluminal sources such as hemosuccus pancreaticus, hemobilia, and aortoenteric fistula. Now, one of the things you can do is determine the likelihood based on age. And you can see for younger individuals, less than 40, you want to first think about neoplasia, polyposis syndromes, and then down the list. Whereas if the patient's older than 40, you're going to think more about angioectasias, dual foie lesions, as well as NSAID enteropathy. And when you look at the epidemiology and natural history, we don't know a lot, But the type of lesion, as I said, can correlate with age, but not gender or ethnicity. Angioctasia overall are the most common lesions. Risk factors include advanced age, aortic stenosis, chronic renal failure, or LVADs. And recurrent bleeding from angioctasia correlates with the number of lesions, advanced age, presence of comorbid conditions, and anticoagulant therapy. Angioectasia, again, are the most common. They are also called angiodysplasia, vasculectasia, and AVMs, but the term we like best is angioectasia. And they are abnormally dilated, tortuous, thin-walled vessels involving small capillaries, veins, and arteries. And the most common cause, they are the most common cause of small bowel bleeds. Endoscopic therapy is safe and effective. The problem is rebleeding rates are high. So this capsule shows a nice typical angiodysplasia, and there are theories of how they develop. There are mechanical versus angiogenic theories, but the vascular lesion has a very different appearance from red spots. It can have that irregular spider-like border. Interestingly, no villi is seen within the vascular structure, and the lesions tend to be larger than a single villus. So when we look how to diagnose it, we use capsule endoscopy, and there are two main types. There are the wireless capsules that transmit images to a receiver, and then the wire-free capsules that store images in the device itself. But so far, no significant differences have been shown in head-to-head comparison trials, so you really use whatever you are comfortable with. We know that it's very good for occult bleeding, and if you see blood like this in the small bowel, it's a pretty good chance that that's where the bleeding is coming from. But it also is good for iron deficiency anemia, and in this systematic review, the typical scenarios for small bowel evaluation, again, you want to rule out things like celiac disease, gynecologic disease, or hematologic disorders. But otherwise, you will use the capsule in unexplained iron deficiency anemia, even with negative fecal blood tests. But remember, it's not necessary with a fecal blood test in the absence of iron deficiency anemia. So in this study, the pooled diagnostic yield was 47%, and so we do use that in those situations. Now, how can the yield be improved? Certainly the yield is greatest. Like any other endoscopic procedure, the yield's improved if you do it as soon as possible after bleeding, and preferably on anticoagulation. In hospitalized patients, early deployment within 24 to 72 hours of admission, and other characteristics that increase the yield include overt bleeding, anticoagulant use, inpatient status, male, older age, and particularly liver and renal comorbidities. The yield of capsule is significantly reduced if not performed within 2 weeks of the bleeding episode. You also can get into a condition where you have decreased yields because either the poor bowel preps, incomplete studies where it doesn't reach the cecum, and you can see the risk factors include hospitalization, surgery, narcotic use, delayed gastric transit, and decreased physical activity. And so the solutions for this are to keep the patient ambulated if you're going to do it in the hospital, use endoscopic placement, or in my preference is just to try to do it as an outpatient. The ideal bowel prep isn't known, but a recent randomized prospective study suggested that bowel purge does not improve visualization or diagnostic yield, so we no longer use a 2-liter prep, we just do a clear liquid diet. What about precautions to minimize capsule retention and other adverse events? Well, capsule retention is defined as the presence of the capsule within the small bowel for more than 2 weeks or requiring an innovation to facilitate passage or retrieval. In most cases, though, it's not anything you have to worry about because patients tend to be asymptomatic. The overall retention rate's 1.4%. It does go up in Crohn's disease, and other risk factors include strictures, NSAID enteropathy, tumors, diverticular disease, hernias, history of GI obstruction. So in high-risk patients, we recommend considering a patency capsule and/or cross-sectional imaging to help determine patency of the small bowel. Now, you want to, in most cases, try to perform it for an indication that is appropriate. And you see on the left, that includes small bowel bleeding, iron deficiency, Crohn's, inherited polyposis syndromes, abnormal small bowel imaging, or complicated or refractory celiac disease. But you can see on the right, for low yield indications, you can still do it, but the yield's gonna definitely be better if you do it for an appropriate indication. If you're gonna do it for a non-standard indication, like on the right, then I think it's important to document that in the medical chart. Take-home points for optimizing capsule in clinical practice is, again, make sure that you document the indication and a brief clinical history. You want to document whether it's endoscopically placed or orally placed. You want to really clearly document the gastric and small bowel transit times, document the quality of the bowel prep, make sure you get images of the landmarks, talk about the completeness of the study, comment on retention if indicated, and then clearly state diagnostic findings and plan of care. And when you talk about adequacy, you can see on the right, you really want to make sure that the study was complete, that there was an adequate bowel prep quality, and that the small bowel transit time was at least 2 hours, because we think if it's less than 2 hours, there's an increased chance that we might miss lesions, particularly single mass lesions. So moving on to deep enteroscopy, we can talk about double balloon, single balloon. The spiral overtube was initially a manual device and then became motorized, but it is actually no longer being used because of concerns about increased complications. In any case, the benefit in deep enteroscopy is that you can do biopsies and you can do therapy. And so in the systematic review, you can see that the most common indication was small bowel bleeding, and the pooled detection rate was 68%, and the lesions seen were vascular, inflammatory, neoplastic, and diverticulum. Now, just to show you how we normally do it, you can see that in this particular patient, after a capsule endoscopy, we found this adherent clot in the small bowel, likely the source. And so typically what we do at that point is wash off the clot, then we inject with epinephrine, as you see here, and then in most cases we will apply APC. Occasionally we'll also do clipping, and then in majority of cases, because in case we have to come back, then we will also place a tattoo so that the area that we treated could be more easily found. Now, which device scope should be used and in which direction? I think you can use double or single balloon, and it complements capsule in many cases of suspected small bowel bleeding. If a lesion is identified on capsule, then deep enteroscopy is usually the next diagnostic and therapeutic tool, and all have similar diagnostic and therapeutic yields, although double balloon may have a higher total enteroscopy success rate. In terms of complications, the overall complication rate is similar to routine endoscopy, about 1.2%. It does increase, as you might imagine, with therapeutic procedures. Single balloon has a similar complication rate. Most commonly, you'll see bleeding or perforation, and rarely pancreatitis with antegrade double balloon. It has not been seen with single balloon. And the risk of perforation may increase in patients with surgically altered anatomy as well. What about improving the diagnostic yield? Again, the yield is highest when performed within 72 hours of overt bleeding. The decreased yield occurs when performed greater than a month after overt bleeding. Higher yield also is better when preceded by a capsule because it directs you in the appropriate area of the small bowel. And it's important to adequately resuscitate the patient prior to the procedure. Hemodynamic factors and medications really affect visualization of the angiodysplasia, and blanching of angiodysplasia with narcotics and Demerol can also occur. Recognition of the lesions obviously improves with expertise and training. Just as with capsule, it's important to perform it for an indication that's appropriate. Small bowel bleeding, suspected tumors or polyps, inflammatory bowel disease, foreign bodies, small bowel strictures for dilation or therapy, placement of percutaneous endoscopic jejunostomy or access for ERCP, and then evaluation biopsies for malabsorptive syndromes and/or refractory celiac disease. It's ideal if you can guide the approach with capsule or cross-sectional imaging before deep enteroscopy, and there's no specific contraindications beyond other endoscopic procedures. The only thing is if you have strictures present or substantial adhesions, then you obviously want to be careful. So tips regarding quality balloon-assisted enteroscopy. The important thing is with any procedure, demonstrating competency, reviewing capsule studies or CT-MRs before the procedure rather than just going ahead, documenting the peri-procedural anticoagulation plan when pertinent, base the insertion route ideally on the capsule transit time or CT or MR, perform in a timely manner after bleeding. We always use CO2 inflation instead of air. Mark the most distal point of the advancement with a tattoo and treat clinically significant lesions, preferably during advancement, and then be prepared to identify and manage complications. Now, as I said, it's ideal if you use capsule as a screening tool because the transit times are useful, and we recommend an antegrade approach for lesions with a time index value of less than 0.6 of the pylorus to cecal time. So if it's in the first 60% of the small bowel, go to antegrade, retrograde for more distal lesions. And an antegrade approach has been shown to have a greater diagnostic and therapeutic yield, likely due to the higher prevalence of vascular lesions in the proximal small bowel. And remember, a negative capsule allows for the avoidance of deep enteroscopy in patients with a low pretest probability for small bowel findings. Now let's talk about therapy a little bit for the vascular lesions that you find. For angioectasias, we can use cauterization. Doulophos, you have injection, cauterization, hemoclips, or surgery rarely. And for AV malformations and hemangiomas, you can consider injection, cauterization, banding, sclerosins, and again, surgery. In LVAD patients, combination therapy with clipping and APC may have a higher success rate. For angiodysplasia treatment options in particular, we mostly use argon plasma coagulation because the depth of coagulation is superficial, and you can control that cautery depth through the gas flow and duration. But you still can use heatoprobes or bipolar electrocautery, although I don't usually. You can also use sclero, hemoclips, and even there's a small trial with an RFA catheter. But there really are no prospective randomized controlled trials that compare all these different modalities, but I think most people use APC. So this was a 62-year-old with a hemoglobin of 2 when he came to the ED, my lowest hemoglobin I've seen. Colonoscopy was negative, and upper endoscopy showed angioectasia in the stomach. And you can see we did the small bowel capsule, and he had angiodysplasia throughout the small bowel, and we went down there. There was even fresh blood. And so this is an ideal patient that you can use APC to treat all of these angiodysplasia. But you have to realize that you're never going to do all of that in one session. And this is someone that's going to have to come back for several sessions. So the next thing I wanted to talk about is when should radiologic imaging be considered in small bowel bleeding? So the indications include when capsule's negative or contraindicated, when there's brisk bleeding and hemodynamic instability, or suspected Crohn's disease or mass lesions. And there are a lot of options, but most of the time we use multi-phase CT scans. Although if we're thinking something like Crohn's or a mass lesion, we may use MR or CT enterography. The multi-phase CT scanning is useful for acute and chronic small bowel bleeding, and it can complement the capsule. And the reason I like it is it has these three phases: a bolus-triggered arterial phase, then the enteric phase, and the delayed phase. And the pre-IV contrast imaging is followed by a rapid bolus of IV contrast, and then followed by the arterial and venous phase imaging. Now, a CT angiogram is preferred for active bleeding. So, and the reason, and because that can direct mesenteric angiography and embolization, and you're not giving them oral contrast because they're actively bleeding. CT enterography is best for chronic bleeding because you're looking for masses or you're looking for inflammatory bowel disease. But this is an example. Again, you have the three phases: the non-contrast scan, the arterial phase, and then the venous phase. And you can see in this study, we were able to find a jejunal bleed as you see the increase in blood as you go through the three phases. And that's what's nice about this. It allows you to catch bleeding better than a single scan. So multi-phase CT angio without oral contrast should be considered, especially when endoscopy is not diagnostic. And just to give you an example, this is a 54-year-old who had recurrent bleeding. He actually had 2 negative capsules, and we know capsules can miss single mass lesions. I did a multi-phase CTE, and you can see it did pick up in that red circle a hyper-enhancing lesion. And sure enough, we did double balloon and found this polypoid lymphangioma. And so it's important to realize when multi-phase CT scanning can be useful. Capsule does detect more angioctasias, but CT enterography or imaging will detect more tumors. So what's a reasonable approach? I think for most small bowel bleeding patients, capsules should be performed before deep enteroscopy. For active bleeding, we often go straight to deep enteroscopy. If no source is identified, then consider a multi-phase CT. For active bleeding, again, we'll do the multi-phase CT angiogram. And for obstructive symptoms or suspicion of IBD, we would do a single-phase CT or MRE. When should you consider pharmacologic therapy? There's limited data, but the ideal candidate is someone who has refractory bleeding and multiple comorbidities and contraindications to endoscopy once a serious lesion has been excluded. We think that hormonal therapy doesn't have much proven benefit, but somatostatin analogs appear to decrease rebleeding and transfusion, and thalidomide also is effective. And you can see here, I just wanted to show you the dosing for the somatostatin, thalidomide, and even the bevacizumab that can be used. They do have side effects, but overall, they're fairly well tolerated. I think the challenge still lies in the fact that many patients still have recurrent bleeding, even if you've identified a source. And there's uncertainty whether angioectasia detection and ablation affects long-term outcomes, because most of the time the angioectasias are not actively bleeding when detected. The bleeding source can be found in 80%, but even when you find it, rebleeding occurs as many 30 to 45%. And the risk factors for rebleeding include Hyde's syndrome, anticoagulants, age greater than 65, number of vascular lesions, chronic renal failure, large transfusion requirements, left ventricular assist devices, and cardiac arrhythmias. So in the setting of recurrent bleeding, the next steps, we really don't have any good prospective studies. But don't forget that second look endoscopy, because you may be missing something in the colon or the stomach. And in the setting of recurrent bleeding, we'll often repeat a capsule. We may do deep enteroscopy from the opposite route for total enteroscopy. We'll consider, as I said, multi-phase scanning. And then also in the right setting, just consider medical therapy with oral iron, iron infusions, or somatostatin thalidomide, and of course stopping anticoagulates if you can. But there's limited data, and clinical experience suggests a benefit for intervention if you can. Whether additional tools available in refractory small bowel bleeding, well, don't forget about a Meckel scan in a young man. That's important. Consider a trial, again, of oral or IV replacement. And if no response to conservative management, then repeat endoscopic imaging evaluation, preferably on anticoagulation if you can. For more serious bleeding, we rarely do provocative angiography where we give heparin to see if they'll bleed. Always consider Hyde syndrome and, if present, aortic valve replacement. And surgery is considered a last resort. And so I'll leave you with this diagram, which shows what you might do if they're hemodynamically stable, which is what I went over, versus if they're hemodynamically unstable. Then you might obviously go to a CT angiogram and then a mesenteric angiogram with embolism. But otherwise, we will do the routine sequence of capsule and then deep enteroscopy and or cross-sectional imaging. And with that, I thank you for allowing me to speak today.